going to be talking about comorbid anxiety and functional gastrointestinal disorders. Now, instead of saying functional gastrointestinal disorders, a lot of times I will end up saying GI disorders, or as we talk about later in the presentation, recurrent abdominal pain. So a lot of times those will be interchangeable. Okay. Okay, so the objectives, we will explain the brain-bowel connection, and this is through the autonomic nervous system, the hypothalamic pituitary axis, and the central nervous system, more specifically the limbic system, which is part of our CNS. We will discuss GI disorder criteria as well as symptoms, and again, this includes recurrent abdominal pain as well as irritable bowel syndrome, or IBS. We'll determine the association between anxiety and GI symptoms, talk about the screening tools that were used in the studies that I had gone through to get the information for this presentation, data, as well as limitations of those studies, implications from those from the research data, and then quality improvement as to what we can do in practice to improve our results. Okay, so starting off, I actually included this quote because it worked perfect. One of the most consistently reported and debilitating symptoms in anxious children is abdominal pain. And that's from the Journal of American Academy of Child and Adolescent Psychiatry. So now let's talk about the brain-bowel connection. So these two work in a highly integrated way through a bidirectional communication. As mentioned previously, involves the autonomic nervous system and the HPA axis. And the central nervous system via the limbic system is essential for control of emotions. This is exactly the same diagram that I used for last week's presentation. Goes into detail about the autonomic nervous system and all the parts that it controls. Now, looking in the middle column, dry mouth, blood pressure, respiratory rate, heart rate, bowel motility. So bowel motility, that's going to play an important part here. Okay, so the limbic system. It plays a central role for emotion. It's a nonverbal system that facilitates survival, threat, avoidance, social interaction, and learning, and involved in the modulation of visceral pain and visceral perception, which then facilitates the mind-body interaction. Just a diagram of the limbic system, which itself, as you see on the left-hand side, the hypothalamus is part of our endocrine system. Now, the biopsychosocial model. This model attempts to explain the relationship between the GI function as well as the central nervous system. Now, the pathophysiology of functional gastrointestinal disorders isn't fully understood. And that's one of the limitations we're going to talk about when it comes to studies and research done linking both anxiety as well as FGID. But some, based on the biopsychosocial model, they are multifactorial. Theories have indicated stress, bowel hyperreactivity as being, the main contributors. So here's a diagram of the biopsychosocial model of health. Pretty much biological, social, and psychological factors all coming together, overlapping to affect health. A little talk about anxiety, especially in the pediatric population. So anxiety disorders, one of the most common forms of psychopathology in children, prevalence of about 10 to 20%, and these often precede other mental health disorders. For example, those who have childhood or adolescent anxiety, often in adolescence and adulthood, will have coexisting depression. And the associations between recurrent pain and anxiety. So there is evidence of an association between physical and psychological problems in children and adolescents. And so since we're talking about pain, these include stomach aches, headaches, and musculoskeletal pains. And they were found to be strongly associated with anxiety, depression, and behavioral disorders in children ages 9 to 16. Physical symptoms are often part of the criteria for a psychological disorder. For example, repeated complaints of physical symptoms in times of stress. So, and then number 3, pain symptoms may exacerbate or contribute to psychological symptoms and vice versa. Perfect example. A child with recurrent nausea induced by her stomach aches may become anxious in situations in which she may be far from a restroom, and as a result, she may refuse to leave home to attend school or any other social functions. Her avoidance of social situations may, in turn, increase her anxiety when she anticipates or is forced to engage in activities outside the home, which may then exacerbate her GI symptoms. It's like a vicious cycle. Now we're going to talk about FGID. Per the definition, it's a variable combination of chronic or recurrent GI symptoms not explained by structural or biochemical abnormalities. And that's what separates something from being functional versus organic. If there's an organic cause, then it can medically be linked to something, whether it's a gallbladder issue or if it's constipation, anything like that. So FGID is something that cannot be explained organically, so it is functional. It's due to the altered functioning of the gut's nerves, muscles, and hormones without any known cause. And it develops through an interaction between the functioning of an individual's body, such as pain sensations, psychological factors, negative thinking, and social factors such as withdrawal. Now, this is the Rome-3 criteria, which is used for the actual diagnosis of functional gastrointestinal disorders. I'm not going to go through all of them, but we see vomiting, and anytime you see aerophagia, and aerophagia is basically when swallowing too much air is going to result in increased gas. That's what that is indicating. And then the adolescent rumination syndrome, which I wasn't too familiar with, to be honest, so I was reading up on that. That is actually a chronic mobility disorder where there's effortless regurgitation of most meals right after consumption. Aside from that, we have abdominal pain, functional dyspepsia, IBS, abdominal migraine, functional constipation, and non-retentive fecal incontinence. So comorbid anxiety and FGID. So there are higher levels of somatic complaints in anxious children, and these altogether are associated with poor school attendance, school refusal, poor academic performance. They tend to interfere with peer relationships or participation in any family events, and overutilization of healthcare system and unnecessary procedures being done to find out exactly what's causing their, for example, abdominal pain that's happening so frequently right around the time that he or she needs to go to school. Now, recurrent abdominal pain, or RAP, this concept arose from evidence that many children who previously met criteria for recurrent abdominal pain now meet the criteria for one or more FGID symptoms. Studies show children with medically unexplained abdominal pain, they tend to be more timid, nervous, anxious, or overconscientious. And in these children, an emotional disturbance is likely to develop. And then for completion's sake, I added a slide on irritable bowel syndrome, which is a chronic disorder characterized by abdominal pain, abdominal discomfort, and change in bowel habits without organic causes. It leads to altering bowel habits, such as constipation and diarrhea. And research has shown that in 44% of patients with both anxiety disorders, symptoms of abdominal pain, diarrhea, and nausea have been found together with comorbid IBS, which definitely makes sense. For example, if, let's say, when I'm seeing an adult patient with alternating bowel habits, and let's say their diet is okay and it's not due to dehydration, they're getting enough water in their system, we send them for a colonoscopy to rule out inflammatory bowel disease such as Crohn's or ulcerative colitis. Once that's ruled out, they're not constipated, then usually as a diagnosis of exclusion, that's where the GI doc will diagnose them with IBS, pretty much emotionally induced change in bowel habits as a result of stressors. Okay, so now a little bit about RAP, such as the criteria, incidence, and prevalence. It is the most common recurrent pain complaint of childhood. It must occur at least once a month for at least 3 months. It must be without an organic cause, periumbilical, meaning right around the belly button, and not related to specific physical activity. It affects between 8 to 25% of school-aged children ages 9 to 12. It is more prevalent among girls, but of course both genders can present with it, and accounts for 2 to 4% of pediatric office visits. Now for data gathering, the studies are limited, but used both self and parent report questionnaires as well as diagnostic interviews. That's a typo. Children with RAP were then compared to a group of children with anxiety disorders and a healthy control group. Screening tools, without going into too much detail, but there was the CBCL, which is a child behavior checklist. It's a 120-item checklist that helps assess emotional, behavioral problems, social, and academic performance. There was the YSR, which is the Youth Self-Report, the MASC, or the Multidimensional Anxiety Scale for Children, the ADISP, this through modules for all anxiety, depressive, and developmental disorders. And this, based on the studies that I was looking through, this was done through telephone administration. Then there's the Spence Children Anxiety Scale, one for parent, one for children. And then the SCARED questionnaire, the screen for child anxiety-related emotional disorders. And then to basically gauge or get a better understanding of how their GI symptoms are going, the QPGS, or the Questionnaire on Pediatric GI Symptoms, using the Rome criteria for FGID that we went through earlier. So this is just a sample of the SCARED questionnaire. You'll see about 5 questions on the left and right. One is for the parent to answer, one is for the child to answer. So I am shy. People tell me I worry too much. I am scared to go to school. I get really frightened for no reason at all. I'm afraid to be alone in the house. So all this will help them gauge as to how anxious the child really is, and also ask the parent about how they would rate their child's anxiety. So the results. So children ages 6 to 13 with anxiety disorders were significantly more likely to have symptoms of functional gastrointestinal disorders compared to children without any anxiety. And the ratio was 41% versus about 6%. Also significantly more likely to have symptoms of functional constipation and higher incidence of IBS symptoms. Higher anxiety symptom severity was characteristic of anxious children with symptoms of FGID, and also more likely to suffer with anxiety disorders such as generalized anxiety disorder, separation anxiety disorder, and phobias, both specific and social. Implications. So recurrent abdominal pain and anxiety may be distinct, but exist as comorbid disorders. Recurrent abdominal pain may be a subtype of an anxiety disorder in that the presence of persistent and significant abdominal pain is a distinguishing feature of a distinct subtype of anxiety. So they're kind of characterizing it as a form or a subset of overall anxiety disorders. RAP is characterized by a single symptom, which is abdominal pain. So therefore, may be a symptom of broader anxiety syndromes or disorders. The strong association between abdominal pain and other symptoms of anxiety may reflect the centrality of abdominal pain as a key symptom of anxiety. Now, the limitations to the research. There were several factors which caused these limitations. So the sampling size, such as inclusion criteria. For example, how are we going to select which children get measured? I mean, is it by age? Is it by race, gender, ethnicity? All that plays a part. When the studies were actually getting the results back, it was through parent reporting. So is it symptom perception again, or do parents have a higher symptom perception of their children's symptoms? A lot of times that also, I mean, there have been studies done on that too, where if the parent has specific GI symptom or their anxiety is a bit, overboard, then they're more likely to have increased symptom perception based on their child's symptoms. So yeah, that's the familial component and the bias that I just mentioned. And vague somatic complaints making the diagnostic criteria difficult to implement. I mean, even constipation, for example, are they drinking enough water? Is it, something diet related? So, how are we to know that if somebody's presenting with constipation, anxiety is the only thing that's contributing to it? So that's, some of the limitations for the studies. So quality improvement. So improving screening methods to detect elevated GI symptoms in children with anxiety. This may interfere with treatment outcome or be a risk factor for relapse if avoidance and distress associated with pain and toileting are not recognized and dealt with accordingly. Another way we can do it is by educating the parents about GI functioning and how it contributes to and may help in the maintenance of their child's anxiety. CBT, as always, for childhood anxiety disorders, and usually when coupled with SSRI medications, both the CBT as well as pharmacologic therapy shows the best results. CBT has been shown to help decrease pain symptoms in children with functional abdominal pain. Pinpoint more specific criteria to account for the symptoms of functional gastrointestinal disorders. And one theory even said, diagnosis of IBS by psychiatrists may help contribute to treat anxiety and depressive disorders accordingly. And again, same diagram used last time for cognitive behavioral therapy. Thoughts create feelings, feelings create behavior, behavior reinforces thoughts. Any questions?